Touch. Okay, Brianna, today I think we'll discuss dysfunctional uterine bleeding.
Yeah, it's a big topic and oftentimes it's a little confusing.
Yes.
Yeah, so we're going to hopefully make it enjoyable.
I made it short.
Excellent. Why do you enjoy this topic?
Like that, every topic I enjoy.
Dr. Hirma, Heart Obstetrics and Gynecology. That's it.
Okay. Dysfunctional uterine bleeding. Definition. It may be defined as abnormal bleeding from the uterus, unassociated with tumor, inflammation, pregnancy, or other organic disease of the genital tract. DUB is essentially diagnosed by the exclusion of organic disease. So it includes a group of menstrual disorders of different etiology and is not a specific diagnosis. The diagnosis of DUB depends on the care and trouble taken to exclude organic lesions. So any series will inevitably include some cases that organic disease has been overlooked. Abnormal bleeding occurs in various forms: menorrhagia, polymenorrhagia, polymenorrhea, metorrhagia. Classification of DUB. The abnormal bleeding can be ovulatory or anovulatory, and in between the two, it may be due to corpus luteal problems. Now, this classification depends on the ovulation. Now, another classification for management point of view depends on age. One is adolescent or pubertal DUB. DUB during reproductive age 20 to 40 years. Perimenopausal DUB is above 40 years. Incidence varies depending on the care taken to exclude organic disease. Etiology. DUB may occur at any age, from puberty to established menopause. The first group is presumed to be endocrine disturbances in the HPO axis. This usually occurs more frequently at the extremes of the reproductive life, during adolescence and menopause, when menstrual function is being established or is declining. During the second phase of the menstrual cycle, luteinization is likely to be defective during these periods. In pubertal DUB, the primary factor lies in the pituitary gland. Gonadotropin secretion is disturbed. In perimenopausal DUB, in contrast, the fault lies in the ovary, which fails to respond to gonadotropins. In both cases, there is failure of ovulation and annullity bleeding results.
So for perimenopausal and pubertal DUB, it's usually anovulatory related. Okay. What about in the childbearing period?
In the childbearing period, usually ovulation is normal, but the fault lies in the corpus luteum, which fails to complete its normal cycle of luteinization and atrophy. Decreased secretion of progesterone in the second half of the menstrual cycle results in irregular ripening. Prolonged activity of the corpus luteum and results in irregular shedding.
Both which can cause DUB.
DUB. Now these are problems with ovulation. Now another major group where local dysfunction in the endometrium. So far endometrium was not involved.
It was just the hormones related to the HPO axis.
Hormonal axis. Since long time, DUB was attributed to disturbance of the HPO axis, as previously described. But recent studies indicate a prominent role for local factors in the endometrium. The endocrine dysfunction does not usually operate in adult reproductive DUB. Probably in these, local dysfunction in the endometrium prevails. Increased levels of PGE2 results in vasodilatation of spiral arterioles in the uterine endometrium, Therefore, probably factors that alter synthesis and metabolism of PGE2 are more important in reproductive age DUB.
And like we talked about before, there's no way to really diagnose PEGE2
No.
deficiencies or abnormalities. We just have to treat empirically.
Empirically. Then dysfunction in the other endocrine glands like hypothyroidism can cause menorrhagia. Then hemopoietic system disorders, blood dyscrasias to be thought of in adolescent DUB. Anemia, iron and protein deficiency, decreased tissue iron and increased fragility of vessels results in bleeding.
I find this an interesting point because we often associate anemia as a side effect
Result
of DUB, but it can be a cause.
Cause.
It can be a vicious cycle.
This is a vicious cycle. Good. You're quite intelligent.
Oh, thank you.
Good. Psychogenic factors operate in adolescent DUB because just then they would have attained menarche, so they are not used to that menstrual bleeding,
Right.
changing of diapers and all.
And,
So they may get tension and worry, that sort.
And stress and worry can also contribute to DUB as well.
Other systemic disorders like chronic hepatic disease, that is cirrhosis, coagulation defects, chronic renal failure, and severe hypertension. Drugs, oral contraceptive pills, IUD, cause menorrhagia. Etiology of pubertal DUB. First and foremost, the common endometrial findings are normal endometrium in majority. That is, normal means DNs in the second half of menstrual cycle will demonstrate secretory activity. This is the common picture.
Right. So even if they're having DUB, we do an
secretory endometrium.
Right.
Then next is proliferative endometrium. Demonstration of proliferative endometrium in the second half of the menstrual cycle, usually seen in adolescent and perimenopausal age. Third, endometrial hyperplasia. Irregular ripening, irregular shedding may sometimes be found. Irregular ripening is the finding of a mixture of both proliferative and secretory endometrium in the second half of the menstrual cycle. Causes of irregular ripening: functional defects in the corpus luteum or irregular response of the endometrium to normal hormonal influence. Premenstrual spotting can occur with irregular ripening. Irregular shedding is the finding of proliferative activity in the secretory phase because of prolonged activity of corpus luteum. Irregular shedding leads to menorrhagia. Then cystoglandular hyperplasia,
which is a subtype of endometrial hyperplasia. Yes.
The glands increase in number and size, producing typical Swiss cheese endometrium. Some glands are large and cystic. The stroma is also dense. It is a benign condition and rarely progresses to cancer. In metropathia hemorrhagica, the endometrial pattern is cystoglandular hyperplasia.
What causes this overdevelopment of glands? Hormones?
Progesterone, estrogen and progesterone.
Uncontrolled. Okay. Unchecked. Okay.
Then adenomatous hyperplasia. Here there is an extreme degree of glandular hyperplasia, literally obliterating the stroma, crowding of glands. Further hyperplasia leads to atypical adenomatous hyperplasia. Both these conditions are pre-malignant for endometrial cancer. Atypical hyperplasia. Endometrial hyperplasia is associated with acyclical bleeding. Metropathia hemorrhagica. Endometrial hyperplasia occurs because of continuous continuous action of unopposed estrogen on the endometrium. Ovaries. Ovaries are usually normal. Multiple follicles are formed in metropathia hemorrhagica, and uterus usually normal, except in metropathia hemorrhagica, uterus may be slightly enlarged. Abnormal bleeding occurs in various forms: menorrhagia, polymenorrhea, metrorrhagia. Now, menorrhagia is excessive bleeding during periods or prolonged bleeding. That's called menorrhagia. Polymenorrhea is frequent menstrual periods. Polymenorrhagia is frequent episodes and also in excessive amount. Now, pubertal
What about menorrhagia? What's the difference with metrorrhagia?
Metrorrhagia is acyclical bleeding, irregular, in between.
Oh, okay.
But that's not actually the feature in DUB, because there actually everything is normal. It's a feature of malignancy. Now, pubertal DUB.
So what's the endometrial picture in most cases in pubertal DUB?
75% normal, 15% cystoglandular hyperplasia. Now, after menarche, 30 to 40 cycles are usually annulatory in normal pubertal girls.
Right, so we would expect some abnormal uterine bleeding in the first few years.
Yeah, that is
menarche.
normal, functional. And that can get corrected by itself once regular
Self-limiting.
And ovulation starts. You understood quite a lot. I don't know, with this knowledge, what you will do in America?
I don't know, take over the world. With all my knowledge about DUB, I will take over the world.
Pick up cases from there,
yeah,
and call me for treatment.
Okay. Well, you know, I think DUB is underspoken about. I think a lot of women suffer from DUB and never seek help.
Now they seek, now they are oriented. Earlier they used to think it's normal, physiological and kill. But now they are aware. For every slight bleeding, they come.
You're right, they come too much. Okay. What about DUB in reproductive age?
DUB is ovulatory, commonly ovulatory. Endometrial hyperplasia, amenorrhea followed by continuous bleeding. Metropathia hemorrhagica, pathologic abnormal bleeding from the uterus. Essential pathogenesis is absence of functional corpus luteum in the ovary. There is no ovulation. One or more follicles mature and fail to ovulate and form cysts. Glandular cells, granulosa cells continue to secrete estrogen. That's a mistake.
Granulosa, not glandular?
No, granulosa. Cells continue to secrete estrogen. Prolonged estrogen stimulation, unopposed by progesterone, results in typical cystoglandular hyperplasia, usually present in pubertal or perimenopausal DUB.
So it's kind of the corpus luteum, or the follicles, the granulosa cells are going haywire because there's no corpus luteum suppressing the hormones. Because when one cyst ruptures and the corpus luteum is formed, it calms down everything else. Without that one thing calming everything down, the estrogen's going crazy, right?
I can't get you.
So, essential pathogenesis of metropathia hemorrhagica is the absence of a functional corpus luteum in the ovary. So there's no ovulation. And one or more follicles mature but fail to ovulate and form cysts. So the granulosa cells of the ovary continue to secrete estrogen. Typically, when ovulation happens, the corpus luteum is suppressing the granuloma cells from secreting estrogen. Right? So without ovulation, there's no suppression of that estrogen release. Is that correct or no?
I can't understand.
Okay. So in the ovary, okay, typically one egg dominates. Ruptures.
That's dominant follicle.
Right. Ruptures, corpus luteum is the
Formed.
Okay? But in anovulation, when one or more follicles mature but fail to ovulate and they form cysts, those cysts never create a corpus luteum, right? They're just pre-ovulation. So they're continuing to secrete estrogen. The estrogen is unchecked. When ovulation happens, the corpus luteum secreting progesterone suppresses estrogen, typically, right? And so this situation, estrogen is not suppressed. So the unopposed estrogen is what causes the endometrium to go haywire, right?
So hyperplasia occurs.
Right. Okay. What are the classic symptoms of metropathia hemorrhagica?
In metropathia hemorrhagica, variable period of amenorrhea with variable period of continuous and profuse bleeding, usually for 15 days. Bleeding is painless. Amenorrhea may go from 5 to 10 weeks. 30 to 80% of pubertal metropathia show tendency for spontaneous cure once ovulation starts. So treatment is not needed in majority. Diagnosis: clinical history including current and previous medications, for example, oral contraceptive pills, intrauterine device, etc. Age: accurate menstrual history, symptoms of other endocrine deviations, that is hypothyroid state, proper history of psychological background, nutritional status, symptoms of anemia, history of tuberculosis of endometrium, symptoms of systemic illness, cirrhosis of the liver. Estrogen becomes affected in cirrhosis of the liver, so that can cause excessive bleeding. General physical examination for evidence of anemia and other endocrine disturbances, evidence of obesity, acne, hirsutism. In PCOS some cases you get hirsutism, endocrine dysfunction, hypertension. Pelvic examination done in all DUB patients except in pubertal patients with intact hymen. In regular PV findings, usually uterus is normal. In metropathia, uterus is enlarged and ovaries are polycystic. It's enlarged, cystic. PR examination is done to exclude probable palpable uterus, enlarged uterus and other organic lesions. Ultrasound examination under anesthesia, especially in adolescent DUB, when there is recurrent bleeding in spite of treatment. Diagnosed by excluding organic lesions. So let us consider what are the organic lesions in different age groups. In pubertal DUB, organic lesion usually not present, except in some cases endometrial tuberculosis or functioning ovarian tumors are present. Except in reproductive DUB, organic lesion must exclude pregnancy, fibroid uterus, endometriosis, pelvic infection. Perimenopausal DUB must exclude malignancies, fibroids, not common but sometimes we get. Investigations: ultrasound, hysteroscopy and biopsy, dilatation and curettage, fractional curettage. If malignancy is suspected, you take bits in order not to miss these things of different places. Hysterosalpingography and laparoscopy. This will be done when there is failure to respond to treatment. And rarely, extremely rarely, angiogram if suspicious of uterine hemangioma. Venogram, pelvic vein thrombosis. That's also rare. Uterine curettage has threefold objectives: to exclude organic lesion like tuberculosis, small uterine polyp, pregnancy complication like missed abortion, etc. Malignancy, especially in perimenopause, menopausal age. To know hormonal status, secretory or proliferative phase.
So we're sending the samples collected from uterine curettage to pathology.
Yeah, always listen.
Or can we just look at the tissue and know whether it's secretory or proliferative? No, we have to have it look under a microscope. You can't just tell. It doesn't look like fluffy marshmallows.
Now, third this thing for the DNC is therapeutic benefit. Sometimes DUB gets controlled after DNC. The first 2 to 3 cycles after DNC, bleeding is less because the necrotic endometrium will be removed. So that can cause the spiral arterioles to.
So these are not always chronic issues. Sometimes the reproductive tract gets off cycle and 1 or 2, but then the presence of necrotic tissue can cause continuous problems. We get rid of the necrotic tissue, the problem's gone. Body has balanced out its hormones and everything's around the same. Okay.
Hematological investigations. Hemogram in puberal DUB because blood dyscrasias will be common in such age. Tests for ovulation because DUB is usually associated with infertility, so we have to do side by side that also. Other endocrine investigations because they also are responsible for DUB many times. Hemoglobin, urine albumin, fasting blood sugar, thyroid profile, TSH. Management of DUB. In the management of DUB, 3 principles should be kept in mind. Exclusion of organic disease, make a positive diagnosis of the endocrine defect, individualize the treatment according to age, parity, and severity of bleeding. First, treat the general condition. If bleeding episode is heavy or has caused severe anemia, hospitalization, bed rest, sedation, and blood transfusion. Uterine curettage are now tablet paused tranexamic acid if bleeding is profuse. Clots, continuous soaking of pads in 40%, no recurrence. After curettage, in 40%, there is no recurrence. Hormonal treatment, progesterone, estrogens plus progesterone, androgens, and danazol. These are the drugs used.
Remind me what danazol is again?
Danazol is a drug for endometriosis.
What classification is it? What kind of drug is it?
It is
What's its mechanism of action?
19-hour steroid. It has androgenic action.
Okay. What are the indications for hormonal treatment?
In puberal DUB, where abnormal bleeding continues in spite of general line of treatment, hormonal treatment is started only if the bleeding is severe, otherwise only psychotherapy is given.
Because with time, usually the problem resolves.
In reproductive DUB, if that has not responded to uterine curettage, hormonal treatment is the next step.
But this is based on old recommendations. Now, we
correct.
start with least invasive, so start with hormonal treatment, and then we move to the most invasive.
Now also, ekdam we don't start suddenly. Hormonal treatment is not suddenly started.
Well, DNC is not suddenly done either.
No, everything will be done in a slow way.
Right. We see if there's responses to the least invasive treatment, and then move up the escalation.
Hysterectomy at least is has become obsolete for DUB. Endometrial hyperplasia, the treatment is with high doses of progestins. Widely used to arrest the bleeding. Once the acute episode of bleeding has stopped, combination of estrogen and progesterone or cyclical for 3 cycles given. By this, the pituitary axis corrects. Another treatment option, only progestins given for a long time, 6 to 9 months, for endometrial hyperplasia. Hysterectomy, never done in pubertal DUB. done liberally in perimenopausal DUB, in reproductive DUB only done when other treatment fails. In short, treatment for DUB is the first line of treatment will be psychotherapy, nutritional therapy, and then hormonal line. DNC will be done when hormonal line fails. In reproductive DUB, treatment actually DNC will be done as an investigation procedure, and preference for hormonal treatment in endometrial hyperplasia or recurrence of bleeding. Hysterectomy if both treatments fail, and if not desiring for any more children. But now hysterectomy is rarely done. Perimenopausal DUB hysterectomy can give progestins for endometrial hyperplasia. Can be given for 6 months to 1 year. Can give androgens if bleeding is profuse to arrest the bleeding. The management of endometrial hyperplasia in metropathia, clomiphene citrate in reproductive age if desired for conception. PGE2 inhibitors like mefenamic acid, aspirin, indomethacin, and lastly endometrial ablation.
I have 2 comments. I thought this is interesting, that we can help women conceive even if they have DUB. I was always under the perception that we had to cure their DUB before we can get them pregnant.
No. That because DUB is another result of that too.
Right. So the other thing is that we haven't really discussed is that some people are fine living with DUB, right? Some people
Nobody is fine living with DUB because of bleeding. Why they will be fine?
Right, but
they will think it is normal.
Right. So we have to talk about the quality of life and how severe it is. If they're having DUB and it's not bothering them, do we have to treat it? And this is an empirical question. I don't know the answer.
If it results in anemia or any other pathology associated, you have to treat.
Right. But
DUB will be bothering for all because excessive bleeding, irregular bleeding, nobody likes it. And now at least with fear of cancer, any episode of abnormal bleeding, patients rush to the doctors. And many gynecologists keep on doing hysterectomies and earning on this pretext. If you don't get hysterectomy done, you end up in malignancy, and people are scared of that.
Right, they practice out of fear. It's fear-based. We can't practice out of fear because we can't give everyone C-sections and hysterectomies. Surgery is not the answer.
Yeah.
Okay. So
the management of endometrial.
We already spoke about that. But endometrial ablation is often used as a last resort before hysterectomy.
Iatrogenic causes of DUB, IUD, PGE2 levels, so bleeding may occur. Hormonal contraceptives, heparin anticoagulants, tamoxifen, sterilization probably due to ligation of ovarian blood vessels.
Okay, so we spoke a little bit earlier about some other systemic illnesses and endocrine disorders that can cause dysfunctional uterine bleeding. You wanted to speak a little bit about a few.
Hypothyroidism. Now, actually DUB there is no organic cause detected, but other hormonal disturbances may affect menstruation. So we have to discuss that also. For example, thyroid disorders, hypothyroidism, disorders of menstrual cycle, usually menometrorrhagia, but occasionally even amenorrhea is common in hypothyroid states. Many cycles are anovulatory. Often the mid-cycle gonadotrophin surge is absent, resulting in anovulation, and progesterone levels remain low throughout the cycle. Estrogen levels are relatively low and constant. Hormonal changes are of those seen in hyperthyroidism. Low sex hormone binding globulin, increased estradiol metabolic clearance, increased estriol at the expense of estrone, enhanced conversion of estrogen to testosterone, increased levels of circulating androgens. This results in hirsutism and other hyperandrogenic features. And dysfunction of no, that is
So
in hypothyroidism. The menstrual pattern is anovulation is always there, and amenorrhea.
What's more common in hypothyroidism? Amenorrhea or amenometrorrhagia?
Menorrhagia.
Usually hypothyroidism causes excessive bleeding because of the unopposed estrogen, because of the anovulation.
Whereas in hyperthyroidism, it is oligomenorrhea and amenorrhea. Possible mechanism of bleeding in thyroid disorders is alteration of metabolism of estrogens and androgens. The conversion of estrone to estriol is increased in hypothyroidism. Hyperthyroidism associated with marked decrease in menstrual flow. Most cycles are ovulatory. Next, amenorrhea and oligomenorrhea may occur.
So that's a brief discussion about thyroid disorders. You want to speak about liver disease too. Liver disease is an interesting one.
Liver disease cause amenorrhea, loss of libido, and infertility. Increased estrone levels due to peripheral conversion of androgen precursors.
We often forget that the liver plays a role in sex hormones.
Sex hormone binding globulin is manufactured in the liver.
Right. So it's an important piece of the puzzle.
Renal insufficiency, creatinine levels more than 5 to 10 mg per ml cause menstrual abnormalities. Uremia causes anovulation. Nutrition and menstrual function. Moderate reduction in nutrition has no effect. Acute malnourishment causes amenorrhea and infertility. Can be rapidly reversed with refeeding. Body weight and menstrual function. Refeeding also, I think, is a correct.
It's correct word.
Refeeding. When you start feeding, let's refeed.
That's correct. So in body weight and menstrual function, hypothalamus.
Body weight also plays a role in menstrual function. Hypothalamic dysfunction in weight loss causes amenorrhea with excessive body weight.
Because of insufficiency of
gonadotrophins. LH lower more consistently than FSH. Decreased body fat will cause decreased conversion of androgens to estrogen. Heavy exercise can cause amenorrhea. Psychological stress and change in lifestyle can also cause amenorrhea due to the effects of estrogen conversion. Pancreas. Before insulin was invented, 90% of patients with diabetes mellitus had amenorrhea. Amenorrhea and oligomenorrhea common. In diabetes, autoimmune endocrinopathies, increase in antibodies can cause premature menopause, resulting in unexpected amenorrhea.
Okay. Is there any other important points you want to make about DUB?
There are. Afterwards I will. After everything is over, I'm going to again reselect everything and make changes.
We're going to make more changes.
Yeah, it's not a perfect talk. So I'll make it a sensible talk. That I'll sit, I'll do it. Once I feed into my pen drive, I'll sit and do it at home. Or I may be with you.
What pieces are we missing? What pieces of the puzzle are we missing?
Not missing, actually. It has to be in that I'll come to know when I'm reading and correcting. But I have to make a nice talk, So I will be changing.
I think we presented it very clearly though, because sometimes this can be a very confusing topic.
This is a difficult topic to manage also.
Yeah. Because most women come in with distress.
DUB and
They're worried
infertility they
about-
come.
yeah.
So that time we have to treat the infertility aspect. After DUB can get corrected by itself. For example, infertility, if infertility is there and this anovulation, then we have to give drugs to induce ovulation, like clomiphene citrate.
Okay. Until next time. See you.
Bye bye, DUB. We were fed up of.
Fed up of you.